شكرا جزيلا دكتور هيثم. شكرا دكتور ريم. صباح الخير زملائي واساتذتي الاعزاء. ان شاء الله النهارده هتكلم عن novel therapeutic approaches in rhabdomyolysis induced AKI. I'll be discussing the definition and epidemiology in very short, etiology, mechanisms of AKI in rhabdomyolysis, markers of AKI, and therapeutic approaches, including the prevention treatment. Rhabdomyolysis means striated muscle breakdown, as you can see, with the release of myoglobin and sarcoplasmic proteins and electrolytes into the plasma. There is no epidemiological studies to estimate the exact percentage of AKI in rhabdomyolysis. However, it's set between 4 and 33% in patients. Etiology actually is very variable, from the famous direct muscular injury in severe burns and crush injuries into severe muscular exercise and seizures, hypokalemia, muscle hypoxia and prolonged immobilization, metabolic disorders, drugs and toxins, the famous statins, some mitochondrial genetic defects, and biological agents such as animal venoms. Mechanisms of AKI in rhabdomyolysis, very short. When there's a release of the myoglobin and the sarcoplasmic proteins, they cause intratubular obstruction secondary to protein precipitation, renal vasoconstriction, inflammation, tubular damage associated with reactive oxygen species release. Here, as you can see, there is muscle damage, occurs fluid sequestration and hypovolemia, which causes RAS activation, causing vasoconstriction. Moreover, the myoglobin causes nitrous oxide scavenging, adding more vasoconstriction, in addition to the oxidative stress, inflammation, and of course, the intratubular obstruction by the protein itself. By the markers of AKI in rhabdomyolysis, we just mean the markers of rhabdomyolysis itself. There's the classic biomarkers. When there is increased urinary excretion of creatinine, uric acid, and glucose, it might indicate that there is associated tubular damage and the process of AKI will follow. And other biomarkers such as the NGAL and KEM1 proteins, which are biomarkers of kidney injury, but however, they have no application in the clinical practice to date. We cannot use them as regular markers. As regards the therapeutic approaches, the mainstay of therapeutic approaches in AKI induced due to rhabdomyolysis is the prevention. There are two landmarks or two milestones: the correction of volume depletion if it's present, and the prevention of the intratubular cause formation. As I said before, the mainstay is to prevent the occurrence of this AKI. It occurs with early and aggressive fluid resuscitation. It helps to maintain a urinary flow, and also it helps to prevent the intratubular cause formation by enhancing, as I said, the urine flow, which will limit the intratubular cause formation by diluting the concentration of the heme pigment and wash out the partially obstructing causes. Who needs prevention? Do we prevent all patients? Of course we do, but who needs the aggressive prevention? For the patients with rhabdomyolysis, whose CK is above 5,000 units per liter, or they have increasing level throughout the follow-up. But pay attention that the CK level typically rises within 12 hours. It reached its peak with 1 to 3 days, and then it normalizes around 5 days after the cessation of muscle injury. Okay. Which IV fluid to use? Ideally, we use isotonic saline, but however, there are no data or studies to choose or comparing one IV fluid to the other. Initial rate, we might start at the rate of 1 to 2 liters per hour, paying attention not to cause volume overload and to follow up for signs of volume overload. However, the initial rate is not important, as the target goal urine output is 200 to 300 ml per hour. Moreover, avoiding volume overload. For how long should I be aggressive with the fluid therapy? I should be aggressive until the patient, of course, if he develops volume overload, I will titrate down his IV fluids, but we should continue until the CK falls below 5,000, or it is trending down, or at least stationary in course. The bicarb, I think that we all use. Urine alkalization, in theory, it inhibits heme protein precipitation with stem horse fat protein, and therefore intratubular pigment cause formation. It also might decrease the tubular precipitation of uric acid. It's given to patients with severe rhabdomyolysis with the criteria we mentioned before. And we might start with infusion of 200 ml per hour, aiming at a urinary pH of more than 6.5. When to stop or when to increase? We have to stop the infusion if the pH does not rise above 6.5 in about 3 to 4 hours, if the patient develops symptomatic hypocalcemia, and if the arterial pH exceeds 7.5 or serum bicarb exceeds 30 milliequivalent per liter. But be aware that despite these beneficial benefits, scarce data suggest that alkaline diuresis is more effective than saline diuresis alone in preventing AKI. They say that saline itself, by the diuresis it causes with aggressive flow therapy, is enough. You don't have to add a bicarb. There are also potential risks to alkalization of the plasma, such as promoting calcium phosphate deposition, inducing or worsening manifestations of hypocalcemia. It might also cause the risk of intratubular deposition of calcium phosphate in the setting of rhabdomyolysis induced hyperphosphatemia. What about the treatment that was the prevention? Treatment of rhabdomyolysis when it's occurred is majorly about the metabolic abnormalities, majorly the hypocalcemia, but beware not to overcorrect the hypocalcemia that occurs initially to avoid the occurrence of late hypercalcemia in rhabdomyolysis. Hyperkalemia should be anticipated and treated according to the usual guidelines. Hyperuricemia, we may give allopurinol 300 milligrams per day if the uric acid is more than 8 milligrams per deciliter, or there's a 25% increase more than the baseline. We do not use respiricase as it's not studied in this situation. When we have established AKI, we treat as any acute kidney injury. We avoid volume overload. We try to maintain the electrolytes. And if there is any indication for dialysis, we initiate dialysis for the sole occurrence of kidney injury. Approaches that we do not use, mannitol. Some studies suggest the use of mannitol as an adjuvant to intravenous crystalloids in non-oliguric patients with traumatic rhabdomyolysis, as it might cause diuresis and it acts as a scavenger for reactive oxygen species, so it decreases the inflammation. But however, it might cause both volume depletion and hypernatremia, and in patients with established AKI, it might cause hyperosmolarity and volume expansion, especially with high doses. Loop diuretics, it should not be a regular practice. However, loop diuretic might be used only if we have an evidence of volume overload, such as heart failure patients, for example. Dialysis for the removal of the myoglobin or hemoglobin or uric acid to prevent the occurrence of AKI, it's not a usual practice. What about the novel therapeutic strategies? And by novel here, I mean there are compounds that we know, but it is novel to be used in the setting of rhabdomyolysis. For example, the iron chelators and antioxidant treatment, such as desferoxamine. It inhibits lipid peroxidation by reducing myoglobin to as ferrous 4. Also, the deferriprone, the oral form of desferoxamine, is used, but it's not tested yet in AKI. Antioxidant treatments such as acetaminophen, N-acetylcysteine, and vitamin C all act by decreasing lipid peroxidation and decreasing the oxygen species to decrease the inflammation and inhibit the pro-inflammatory cytokine release. Also, anti-inflammatory treatments such as the clodronate, ceramide, the treatment for trypanosoma, and pentoxifillin, or act by acting as an anti-inflammatory substances to decrease the pro-inflammatory cytokines and promote the anti-inflammatory cytokines. At last, the mesenchymal stem cells in rhabdomyolysis-induced kidney damaged mice, they act through promoting intrarenal accumulation of the protective M2 macrophages, but yet it's not tried in humans. Also, vasoconstriction, as I mentioned before, is a partial consequence of nitric acid scavenging by the myoglobin, so we might give a nitric oxide precursors or donors, such as the L-arginine, among others. And thank you.